pleasure and honor to host this Catholic Health Hour today. As always, we do have something very interesting for you, a very stimulating discussion, which will be presented by a very experienced clinician, after which we will have our Q&A sessions. So this is our Catholic Health Hour, which is hosted by CAHN and its partners, and we bring these to you every Saturday. Now, today's discussion is going to be one about prostate cancer. So, of course, we all had a lovely Jubilee weekend last weekend, and we had an interesting discussion on monkeypox. Today, we move into a different zone of talking about prostate cancer. Our host for today is a very experienced GP who works in Leeds. He is heavily involved with the Nigerian community in Leeds as well. He's the lead GP for the Allerton and Westfield Medical Centre. We have none other with us today as our host, who is Dr. Abiye Hector-Goma. Now, he will take us through this session. Please do feel free to put your questions in the chat box as we go along, and we will come to it in the Q&A session. So a very warm welcome to you, Dr. Abiye Hector-Goma. I hope I got that right.
Yes.
And over to you. Thank you very much. Please take over.
All right. Thank you so much, Diana. And again, many thanks to the Caribbean and African Health Network and Heather in Leeds for the invite. And there are some things we know already, and there are some things that we don't know. For example, we know that prostate cancer occurs only in men for obvious reasons. Women don't have a prostate gland, luckily. And then we also are aware that people of African descent are more likely to have prostate cancer. We're not quite sure why. We also know that the men of African descent are less likely to get screened. And we're also more likely to present late for care. And we tend to have poorer outcome. Obviously, if you present late for care, you would have poorer outcome. And also it's known that we also have worse patient experience, and the question is why. So for today's conversation, I'll try to look at the structure, brief dive into the structure and function of the prostate gland for us to understand the features of an abnormal function. Then that age-old question, is it nature or nurture? And how do you reach the man to get himself and encourage him to get checked? And if he does get checked and something is not quite right, the journey he goes through. And then finally, a call to action. And we'll try and do all of this in 30 minutes. So this is an enlarged photograph, as it were. If you look at the man standing sideways, so you have the bladder here with the blood vessels and nerves around it. And then the prostate gland sits right underneath the bladder. And then you have the urethra, the water pipe that goes from the base of the bladder, goes in between the prostate and gets into the penis. And that's where a lot of the symptoms and the problems that we see come up. So this is just like a cross section of the same thing. So that's the bladder. And then the prostate, you can see it sits right underneath the bladder. And you can see the urethra going through the prostate into the penis. So in the normal prostate, you can see the nice, lovely urethral passage. But if you look at this one, the prostate gland is enlarged, so it kind of encroaches on the urethra. And that's where most of the symptoms that you find when there's a prostate problem are related to the problems with the passage of urine from the base of the bladder through the prostate into the penis. So online, if you just typed IPSS, if you Googled IPSS, or if you typed International Prostate Symptom Score, it would show you what we normally ask patients. And use this is something that you can do yourself. Is anybody who is here, a man who is listening to us. The 7 questions that are asked in the last month, not just yesterday. If you went out drinking last night, for example, you might find yourself waking up several times in the night to wee. Doesn't mean there's anything wrong with your prostate. It was because you had too many beers last night, maybe. So in the last month, have you had incomplete emptying? You go and pass urine, you go back.
Sorry.
So
we'll see to that.
Then the next one is frequency. Are you passing urine more frequently? Intermittency, does the urine just flow, or it kind of starts and stops? And then the urgency, you need a wee, you just have to go right away, you can't hold it. And then the weak stream. Many years ago, there was this issue. I remember you put a ball in the urinal, a small ball, and can you wee, and your wee is powerful enough to dissolve the ball in the urinal. If it can't do it, it means your stream is weak. And then straining, again, if there's narrowing of the passage, you kind of strain to pass urine. And men who have enlarged prostate sometimes realize that when they strain, the urine doesn't flow. When they relax, the urine flows. And then nocturia is waking up in the night several times. So if you had one or more of these symptoms over the last month, then you need to do something about it. So the question is it nurture or nature? I mean, this is one slide I like. Back in 1970, Lalonde report on the health of Canadians said there are 4 main issues that affect our health: the genes we're born with, our lifestyle and behavior, the quality of health services, and the environment that we live in. So I always say that your genes, you have to choose your mom and dad carefully if you want to have the great genes. So we can't do much about the genes. But a whole new world of genomics has come in with the fact that people are now realizing, scientists are finding out more and more that when people have various diseases, there may be some genes which are abnormal. So a lot more is being learned, but we still have many years to go around knowing more about genes and diseases. So our lifestyle and behavior, our diets, our physical activity, how we care for ourselves are key issues. And one common thing we say is people needing to see their GP and get checked. How individuals seek their health-seeking behavior depends so much on their family. If you have older men in your family who always got themselves checked, they went for age 40 check, they went to check their PSA, they went to check this, it becomes a cultural thing. You also will do that. But if your family, the people around you can't be bothered, then you also, it's likely that you may not be bothered. And if you're in your 40s, 50s, 60s, if your peers, your friends, the guys you hang out with, they don't bother about those things, maybe you too won't bother about those things. So these are the things, the individual's health-seeking behavior, the family behavior, the culture and upbringing, and what your peers are doing will determine what you do. So somewhere, maybe a place like Holland, where everybody's on their bike riding is kind of a way of life. But in some other parts of the world, maybe even in Leeds, not too many people are riding bikes, people are doing it more, but then it's not like a culture where everybody's going on a bike. So what your peers are doing will also determine what you do. And then the quality of health services that we have, both the primary care, secondary care. Many people think they know a lot about prostates, but then they have a poor knowledge of prostate cancer. And then people sometimes, based on quite a few studies, many of our people of African descent, tend to have a mistrust of the health system or their physician. Many people feel they don't get listened to by their clinicians when they go to the health sector. They go to practices, they don't see their kind in the practice as staff. Fear of cancer, people don't want to know. They believe that what you don't know won't kill you. And then where we live, work, play, and pray, the environment that we grew up in, the environment that we work in, the what amenities and facilities we have around where we are, will also have a knock-on effect on our health and well-being. So for risk factors, prostate cancer UK has an excellent thing. I mean, I was in a service station just 4 days ago. I went to pick my daughter, and I went to the men's room, and I saw this lovely QR code on top of the urinal, which I just put my phone there, and I just found very good conversation on the QR code. I think my last slide was a picture of that QR code. So risk factors, the age of the individual, the older a man is, the more likely it is for him to have prostate cancer. So if a man is 70 or 80 and his PSA is normal, for example, he's very much unlikely to have prostate cancer in his 80s or 90s. But your age, your family history, if you have somebody in your family who had prostate cancer, then as a man, your chances of having prostate cancer will be higher than somebody of your age who doesn't have that kind of history in their family. Being Black, being of African descent is a big risk factor. Also, like I already mentioned, the genes, the environment that we live in. So these are, as well as our lifestyle. I mean, the key point around lifestyle is that living with obesity as a man is a significant risk factor for prostate cancer. So whatever can be done, as one supermarket says, every little helps. Any little shift to move the kilograms or the pounds or the stones from right to left would have a beneficial effect on reducing the risk of prostate cancer. So I just put this slide. I know that the Institute of Cancer Research has a big profile study trying to find out why Black men develop prostate cancer at twice the rate of other men. And quite a few other studies are ongoing. The point is that there are some genes that already are known to contribute to cancers. And then some genes are known to help reduce the risk of cancer. So for some people, if the genes that help to minimize the risk, if those genes are less in some people, then that ability is reduced in them. And in other people, if those genes that are associated with causing disease are increased, then that also makes their risk of having cancer. So this big study is one of those that would help us to have a better understanding. So I've put this, it's a bit of a busy slide, but I think it's an important slide. How do you reach the Black man to take responsibility for his health? You know, as I tweeted yesterday that as a Black man, I am a doctor, I know the right thing to do, but many times I don't do the right thing. So knowledge is knowing the right thing to do. Wisdom is doing it. Everybody here, I'm sure, has had one or two things about prostate cancer in the last 5, 10, 15, 20 years. But I'm sure there are many who are here who are in their 50s and 60s who have never had a test to check if they're at risk of prostate cancer. So how do you reach the Black man? The Black man is a son. So perhaps his mother, if she's still alive and she could ask him, have you had a check before? He's a brother he has a sister, he has younger brothers, he has elder brothers, could encourage him. He has friends. He could be a husband, so the wife could be there sweetly telling him, sweetheart, have you got checked? It could be a father, so if he has a son or daughter who is old enough, you say, Dad, I heard about prostate check, have you had yourself checked? And it's a worker, maybe the workplace, it could be an environment where the bosses have a health support program to encourage people to get checked. So these are all opportunities where the man of African descent can be encouraged to see his GP. So where we live, where we work, where we play, and where we pray, you know, so whether it's a church, mosque, Sikh temple, wherever. So it's important that every setting should be an opportunity to get the man of African descent to perhaps have a conversation with his GP for a possible PSA test. And I will talk about the pros and cons of that in a minute. So what happens if you decide to go to your GP surgery? We'll take a history, we'll ask you some of those questions which I had shown about the IPSS symptoms. And then probably somebody will take your blood and do the PSA, the prostate specific antigen test for you. And then we will offer you an examination of your back passage. And this diagram just explains why. Again, that's the bladder, that's the prostate under the bladder, and that's the water pipe. Now, behind the prostate is the rectum, the back passage. So you can see that when we examine the back passage, the front part of the back passage fills the wall of the prostate. And this is quite an important thing to do because of reasons that sometimes people have a blood test and the blood test comes back normal. That could mean that their risk of prostate cancer is minimal, but it might also be a false negative test. So having the examination would give your doctor the opportunity to have a feel of how the prostate is. But even if you're a bit reluctant about having a rectal examination, at least start with one, have the blood test done. If you're man enough, go ahead with the examination of your back passage, which your GP should offer. But if it is nothing, at least have the blood test done. So what are the advantages and disadvantages, the pros and cons of having a PSA test? A good screening test is one that if it says you have this, then definitely you have it. And if it says you don't have it, then you definitely don't have it. What we have for now, the PSA test, is not that perfect. The advantage it has is that we'll see a diagram shortly where many times when people have prostate cancer, they don't have symptoms initially. It's much later that symptoms become obvious. So if you are waiting to have symptoms before you have a prostate blood test, it's great, but it might be a little bit later. But if you did a test, even without symptoms, if you're of that age where you looked at the pros and cons, then it will be an opportunity to have an early diagnosis. And there's always, I think it's said that there's a 95% survival rate over 5 years when the cancer is diagnosed early. So the one advantage is if you have an early test and a diagnosis is made, your outcome is always better. And the likelihood of dying from prostate cancer, there's some research says there's definitely improvement, and some research says maybe not. It's actually very useful for monitoring in those who have already been diagnosed. So if people have a high level and then they've had treatment, then the level of the PSA comes down, and then the oncologists and the other doctors can use that to monitor. And also, if people are diagnosed, a good number of people that have prostate cancer can live with it because it's slow growing. You have two types, one that is slow growing, which you can live through your life with, and one that is aggressive. So having a diagnosis, we'll talk about it anyway, that monitoring could just be checking the levels. If the levels are not rising, then many times nothing needs to be done. Now, the main disadvantage is that for some people, the result comes back positive, but there are a few other things that can cause the PSA to be elevated. So when the result comes out positive, you have to be sent for further investigation. And of course, everybody, both the man, his family, you get concerned. And sometimes after some tests have been done, you're given the all clear. So that has just been, a time of your life, when you were really concerned, but thankfully it came back as a false positive. And then sometimes you do the test and the test comes back normal and you're reassured that everything is fine. But somewhere down the line, you do another test and that one is abnormal. So you can have a false negative. So one of the disadvantages of a screening program where you don't have screening programs as you have for breast cancer, cervical cancer, and bowel cancer is that if a screening program is done, because there are quite a few other conditions that make people to have raised PSA, you can now have a lot more people being treated who normally would not have been treated. And of course, there may be complications of treatment that are the unnecessary worry when you have a raised result. So the truth is that what you don't know may kill you. And that's why at the end of the day, it's good to look at the advantages and the disadvantages. But like we said, advancing age, being of African descent, having somebody in your family who's had prostate cancer before, living with obesity, those are important risk factors for prostate cancer. So these are some of the things that I've just mentioned, which can make your PSA to be raised. Somebody who has a water infection or irritation, just some people who are much older may have a high level, not because they have prostate cancer, it's just because of their age. Some medications can actually cause your PSA to be reduced. Ejaculation 2 days before, up to 2 days before, vigorous exercise, having had a catheter inserted can cause your PSA to be elevated when the test is done. And other things are, people can have enlarged prostate, which is just benign, it's not cancerous, having inflammation of the prostate, anything that stimulates the prostate can also cause the PSA to be elevated. And of course, prostate cancer itself can cause the PSA to be elevated. So quickly here, if your PSA blood test comes back, and there are different levels for different ages. If your doctor sees, other clinicians sees it, your doctor or nurse involved in your care, in your practice level, they see that for your age, the results are much higher than that is expected to be, then you'll be referred to the hospital to see the urologist. Now, a particular kind of MRI scan is now the gold standard. Before, people had needless biopsies whenever their PSA was raised, but with the multi-parametric MRI scan, which is now the gold standard, it takes away biopsies which are not required. So first you have the MRI scan, and if the MRI scan is fine, then you don't need to have any other, you're just reassured. But if the MRI sees 1 or 2 areas which look suspicious, then they go ahead and do a biopsy, transrectal ultrasound-guided biopsy. So here you can see the back passage, that's the probe, and then they're able to access that area and then take a biopsy and have it looked at. And then depending on where things are, a CT scan or bone scan can be required much later as part of the management. So these are the 2 things that you could expect, So like I said, this particular scan is the gold standard. And then I won't go into this. Predict prostate is what the specialist would discuss with the individual to look at your own risk and then come to a decision on whether the management is watchful waiting or the management is active treatment. So the key point is that for every patient, the management is individualized. It's not the general management. They go through the predict prostate and then discuss with the patient. It says that 85% of newly diagnosed prostatic cancer is localized disease. So this is just a diagram showing the prostate. So you can see that here the disease is localized. It's not extended to the wall of the prostate. And before, anybody that had high levels of PSA or they did a biopsy, they found out that it was cancer, they went ahead and did treatment. But treatment is now changed. When people have localized disease, they don't just go ahead and treat. They now decide whether, following diagnosis for these localized ones, what is called active surveillance, watchful waiting, they just more or less monitor the PSA levels. And if the PSA levels increase, either the person has radical surgery or radiotherapy, or they have hormone treatment. So the point here is that the specialists, the dates, many years back, everybody had radical surgery. But now, because a good number of these positive prostate cancers, you can live and die in old age. The prostate cancer is very slow growing. It's not going to kill you. So for that reason, they don't need to hurry up and do anything. They can just monitor the patient. Maybe every 6 months, they see the PSA level. If it doubles in 6 months, then they do something else. So active surveillance or watchful waiting may now be the approach. So for the management of prostate cancer on diagnosis. So again, just a quick one: watchful waiting, active surveillance. Prostatectomy is where they actually go and do surgery and remove the prostate, and then radiotherapy and brachytherapy is, if this is a tumor, they put the seeds directly into the prostate to help kill off the tumor cells. And then these are new techniques also: high intensity frequency ultrasound via the rectum, and then is another form of treatment. So I come to call to action. Haven't had all of this. Like I said, we can have all the knowledge and do nothing. Knowledge is knowing the right thing to do. Wisdom is doing it. So a lot of research is going on. Maybe somewhere along the line, there'll be gene therapy. If some genes are found, they can find a way to suppress them or do one thing or the other. So this is still early days around genes. We cannot choose our parents, so there's nothing much we can do about this, but fingers crossed, more and more things will come from science. One thing that hopefully we'll see in few years' time is having a test that is more specific, so that all the other things that cause the PSA to be raised, a time would come when a particular chemical will be found. If that chemical is raised, it can only be caused by prostate cancer and nothing else. And maybe a time would come where even if it's prostate cancer, they would know whether it's an aggressive form or is a slow growing form. But this is still early days in terms of what knowledge of our genes can do as scientists continue with their research. On our part, lifestyle is the answer to most things, whether it's diabetes, hypertension, heart disease, prostate cancer. The lifestyle things are about the same. We have to cut back on fat, salt, and sugar in our diets, a lot more of vegetables and a bit more of fruits, to be as active as we can, whether it is walking, jogging, running, swimming, using the stairs instead of the lift, parking the car further from your office, all those little things that we can do to make our heart beat faster, make us breathe faster, as well as make us sweat a bit. So exercise, weight loss, however we can do it is important. Getting 6 to 8 hours sleep at night, being happy, because the problems of the world will never go away. Problems at work, problems where we live will never go away, but trying to be happy despite all the challenges in life, and then managing money as best as we can. So those lifestyle problems will never go away, and particularly obesity, and trying to reduce our weight in whichever way we can for us men would help. So health-seeking behavior, I put a big red circle here. At the end of the day, even if you don't have symptoms, if you don't have a test, you will not know if you have prostate cancer. So as men, I think next week is men's health week. We'll talk about that in the final stages. But as men, we need to look after ourselves better. Our health services, we as health workers need to change our attitudes. So final 2 slides. I would say that every man who is 45 and above, every Black man who is 45 and above must ask your GP for a PSA, just to have a baseline, so that if tomorrow your PSA rises, at least you know that you have a baseline. So that's the action plan is, if you're 45 and above, a Black man, if you've never had a PSA test, please request one and have a baseline. If you have symptoms, then definitely you must see your GP. A lot of things have been said about prostate cancer, and unless we do something about it, then all those these statistics about the Black man being twice as likely to have prostate problems compared to the rest of the community won't get better. So last slide then is, if you have your phone here with you, I think you can just put your camera on this QR code and you can check your risk of prostate cancer in 30 seconds. So that's me done. Thank you so much for the opportunity to talk about prostate cancer.
Thank you so much, Dr. Hector-Goma. That was a lot of knowledge passed on to us in those less than 30 minutes. And clearly you've emphasized the fact that knowing is not enough, taking the action is what we need to do. I really like the way you put that question about how can we reach the Afro-Caribbean man and encourage them to, you know, sort of seek help or come forward and ask for help. And that's a really important point that you raised, because we know that it's more tricky. Men probably, for whatever reason, choose not to go forward and seek help. I hope I wouldn't get smashed after this for saying that. But certainly you've given lots of avenues at where people could sort of maximize the opportunity to seek help. So please, let us apply the knowledge, let us seek the help and get help early. You talked about lots of risk factors, you've talked about investigations, management and all of that. And I know that there will be lots of questions for you. Now, just before we zoom into the questions, just for the sake of our listeners and our viewers, so the CAHN Health is mainly done by CAHN and its partners. And among our partners, we've got the Black Health Initiative, we've got Croydon BME Forum, we've got the MPhil Caribbean Association, we've got RAFA International Development Agency, and we've also got Royal House Redeemed Christian Church of God in Sheffield. Now, today we do have the Chief Executive of the BHIP, which is a Black Health Initiative program in Leeds, Heather Nelson with us. So Heather, I'd like to welcome you at this point to ask a few questions, please, because I know that you do have some questions for our speaker. And then after that, I'll carry on with the rest of the questions that we've got. Please do put your questions in the chat box and we will go through them during this session. I've seen a few hands up. If you can type what you want to ask in the chat box. If we do have the chance, we'll let you speak, but sometimes we are overwhelmed with questions and we may not be able to get everyone to unmute. So please kindly type your question. But in the meantime, I hand over to Heather to ask a few questions. Thank you. Are you there, Heather? Okay, right. So while we wait for Heather to join us, I'll just ask a few questions that we've already got in our chat box, Dr. Hector-Goma. So is it possible for someone to be declined a PSA test? Can someone who wants to have a PSA test go to the GP and yet be told, no, you can't have a PSA test unless you've got symptoms? Is that scenario possible? And what might be the circumstance leading to that? Because someone has asked a question about that.
Yes.
Sorry, I'm back. I'm here now. Sorry, I couldn't unmute for some reason.
Don't worry, technology is brilliant, isn't it? You're here now. Okay, so fire away and then we'll come back to the question that I was going to ask.
Yeah, I wasn't really expecting to be asking any questions. It was more about supporting Dr. Goma with any questions that may arrive and to give examples of the work that we do in the region and what we do nationally through our programme. So, you know, happy to hear the questions and support Dr. Goma with those.
In that case, do you want to tell us a bit about what you're doing in the next few minutes? And then we can move on to the questions, if that's all right with you.
Yes, sure. So, good. Is it still morning? Yes, good morning, everybody. I'm the Chief Executive of Black Health Initiative, known to partners and friends as BHI. We launched our cancer program, which was the first, what then was called the Black Age Minority Ethnic Cancer Program in 2014 at the House of Commons, because we were acutely aware of the inequalities and disparities within the cancer patient experience, prostate cancer being one of them. All of us know that it's 1 in 4 Black men to white men, etc. Continuously knowing and having research, but nobody giving us definitive answers. Maybe there wasn't any, but wasn't even told there wasn't any. And we partnered up with various doctors, specialists like Dr. Goma, to give out factual information, to also support those who were going to the GPs and actually being told, actually, you're too young, come back later, only to find out that within Black men, and again, Dr. Goma will emphasize this, but had was presenting at a younger age. So therefore there was a gap, which was or could have been quite detrimental to the Black men. And we also set up, because as somebody said on here, that men are not very forthcoming when it came onto health. So we set up what we called was the men's MOT. And within that, they had, the blood pressure checks, everything. And rather than waiting for initial appointment with the GPs, which sometimes can be a long time, because of the clinicians being there, we could actually contact the GP of the men directly and let them know that there was concerns. So it kind of got rid or addressed that gap that was there. Still ongoing, still now working in partnership with MPC UK and other hospitals, etc., just to see whether, as Dr. Goma says, is it nature, nurture, is it genetic, is it our diet, or is it a combination of all the above? That's what we're doing with the men, but we also do work with other cancer disparities, as in breast screening, cervical, stomach, bowel, etc. So I'll leave it there because I'm conscious of time, but happy to answer any questions.
Thank you so much. Thank you, Heather, for that insight. And it sounds like a really brilliant work that you're doing. And I think there are things that can be replicated as well, isn't it, nationwide, lessons that can be learned, shared and replicated nationwide. So that's really useful. Thank you for that. So great. Our viewers, we've got 2 for 1 today. And so please fire away the questions so that we can make the most out of this session. Right. So one of the questions for you, Dr. Hector-Goma, can prostate cancer return? So for instance, if someone has had prostate cancer, they've been treated for it, is it possible for it to return? Can it recur? Thank you.
Yes, it can recur. Sometimes people maybe are followed up for 5-10 years and everything is been fine, and then they get discharged by their oncologist. And unfortunately, when you think everything is gone, and then one day there's a symptom, and the point is you just have to go back and have a PSA done again. And if your last PSA was unmeasurable or something, suddenly it's risen. It might still be very normal level, but because after treatment your PSA was almost unmeasurable, if you now have even 0.2, that's something that probably will require you being referred again. So yes, it can recur.
Thank you. And would people always represent symptoms, or could it just be as simple as the PSA reading has gone up? That could be
sometimes. Yeah, that's the point, because if you've had it all clear, you probably will not bother anymore. But it might be that some people just kind of an intuition say, look, I've not had a PSA for 2 years. Let me just check it. And then they just check it and suddenly 0.5, which is very normal, but your last one was 0.01. And then that alone requires a re-referral to the oncologist and to the urologist. They can now decide to investigate again.
Okay, thank you. And another question to both of you probably. We know that access to GP is challenging, and I say that cautiously because I'm a GP myself. But I don't think it's a problem isolated just to GPs. I think it's just the national health is bursting at its seams, full stop. Not necessarily that, GPs cannot see their patients. So we know that there is that overwhelming demand, and, it's sort of difficult to keep up. But nevertheless, people still need to receive quality care and in a timely fashion. So we certainly breaking our backs and working around the clock. But the question I have is, if patients are having difficulty accessing their GP for one reason or another, and for instance, we don't have those initiatives that, Heather, you talked about, which exist in Leeds. If someone lives in an area where they don't have access to that kind of initiative, what options do we have? Are there any options, or is it really you've still got to speak to your GP or clinician about this?
Well, in terms of access, I always say that it's not impossible to contact your GP. For example, most practices have e-consult or kind of another way of reaching your GP's online access. So if you want to have a face-to-face appointment, it probably could wait for 2, 3, 4 weeks or forever. But then if you send an e-consult to your GP and you said, I'm a Black man, I'm 50 years old, I've never had a PSA and I've been advised to have a PSA. Could you please book a PSA test for me? There is no GP surgery that will not see that message the next day. In my practice, with e-consult, we get back to the patients within 24 hours. That may be that I'll see you in 2 weeks' time, but you will definitely get a response. And with that, if I got that kind of message, I would just send you a message back to say booking with the nurse, and then I'll request the PSA for you. So if you say I want to see a GP, it may be impossible, but find out, do you have a facility for electronic consultation, and send that message to your GP. You don't need to see the GP, it's just to book it with the healthcare assistant or the nurse to have the test done.
Thank you. Anything to add, Heather? You're on mute, by the way. You need to unmute yourself. All right, okay. Ngozi, can we please unmute Heather? I think she's not been made co-host, so she's struggling to unmute herself.
Okay, I'll do so in a minute.
Thank you.
Angela, can you do that as well? Okay.
Okay.
All right. Heather, you should be, I've asked you to unmute, you can unmute.
Yes.
Yeah, okay.
Thank you for giving me
Sorry
permission
about that.
to unmute. No problem. I think what Dr. Goma said was correct. Unfortunately, we have digital exclusion, which means that a lot of older people, and not necessarily the age, but a lot of people are not confident with booking through e-consult and using other digital ways. So I think, yes, we do need to have access to our GPs, and appreciate that you're all very busy. But what I would say to those who are on this call today is, if you're able to put something together where people can congregate in a community centre once a week, and you can ask some of your professionals, because there's many of primary care workers who will give up their time, because the argument is if you can get people to go somewhere where they are safe and comfortable, the probability of having those who do not attend their appointments actually gets reduced, because you've got them going to a central place where they're comfortable with those who they are au fait with, and getting the basic tests, the blood pressure, diabetes, getting bloods taken, so that would go straight to the GPs, and the GP will pick up on anything that needs to be followed. So I think, yes, we understand that the NHS is in crisis and struggling, and so are the primary care workers, but we ourselves can actually put something together to help ourselves.
Thank you. So that's really useful from both of you. Thank you. And also, just to add to that, I know that digital exclusion is a big problem, and certainly not everyone feels digitally confident. I mean, I still struggle with my IT stuff sometimes, and I'm hopefully younger. But anyway, there you go. So what I know is that some of the older patients are really good with writing letters. I frequently get letters from my patients, saying, "Dear Dr. Asante, X, Y, and Z." So please, you can write a letter as well. I'm not saying that's the normal route, but if you're struggling to get through, let's find a way, because this thing we're talking about is serious business. If you've got symptoms and you cannot reach out, or you cannot get yourself sorted, it could escalate from a point of undetectable cancer to advanced, cancer. So please seek help. And we know that particularly our older patients don't want to bother their doctor. They don't want to be a nuisance. And so they would just happily just be at home and not want to cause any trouble. But we are entreating our patients that, please, if you are concerned about these things, if you're of the right age, seek help and find a way to get through. There's always a way to get through to your GP. And so let's make those ways work. But these initiatives we probably need more of as well. Right, so we'll move on swiftly with the questions. So Doctor, what are some of the ways that we can actively minimize our risk? I know you've been over that slide a few times, but someone would like to know, how can I actively reduce my risk of getting prostate cancer? So what are some of the things, in summary, that we can be doing, or men can be doing, to reduce the risk of prostate cancer, please? Thank you.
Right. So the four main risks, three of them, you can't do anything about them. Your age will continue to rise. If you have a family history of prostate cancer, you can't do anything about that. And if you're Black, you can't do anything about it, even if you wear bleaching creams. So the only thing that you can do something about is your lifestyle. So, and particularly living with obesity as a man, everything you can do to reduce your weight by 1 pound or 1 stone or 1 kilogram, that is the one thing that can help to reduce your risk. So lifestyle modification, reduce fat, salt, sugar, do more physical activity, whatever exercise you can do, please do that. Sleep better, and try and be happier, because all those things have an effect on your weight. But then the one thing you can do is have your baseline PSA test. So you can't, that won't reduce your risk, it will just reduce your risk of a late presentation. So lifestyle is the one most important thing.
Thank you. So lifestyle is the message. There's nothing you can do about the ones that you have no control over, like your race, your age, etc. But lifestyle we can do something about. Thank you. So in line with that, we do have a Healthy Heart session every Tuesday, which talks about lifestyle, talks about diet, nutrition, exercise, and we do treat you to join with a CAHN Healthy Heart session on Tuesday evenings, or any lifestyle improving programs that you might have locally to minimize your risk of all sorts of chronic conditions, not just prostate cancer. Would be really useful. Right, so someone else asking, what's the name of the test? It's the PSA test, the prostate specific antigen test. Thank you. Now, I've got a few hands up, so I would ask the team to kindly help me to unmute. So there's a brother Duncan, there's Gwyneth, and there's Catherine.
So
I know.
There's one,
sorry.
sorry to cut you, Diana. There's one question about my GP refused me a PSA test. And then Prostate Cancer UK website has an excellent section on what to do if your GP refuses a PSA test. The first thing is, if you had the opportunity to ask him or her, why have I been refused? You know, because the truth is that we just get an avalanche of information. People asking for things as GPs is overwhelming. And sometimes we can sometimes be dismissive, you know, if we don't know something. So ask the GP why, and then if you're not satisfied, you can seek opinion of another GP or nurse. And the Prostate Cancer UK page also, you can actually, there's a link for the specialist nurses who can advise you. And I'm sure there's a template letter which you can send to your GP, because if you say, this is my age, this is my family history, or this is my ethnicity, and this is the advice that age 45 and above, I should have a baseline PSA. It's not a national screening, but I am at higher risk. When you put that kind of information, there is no GP in this country who would not do it, because if something happens to you, he or she is going to be held liable. So once you say your age, say your ethnicity, and say this is the current advice, they don't have a choice but to give you the PSA test. Of course, they'll discuss the pros and cons with you and say, yes, in fact, the website has the pros and cons. You can say, I've read about the pros and cons, and I've made a decision that I want the test. When you put that in an email or an e-consult or face-to-face consultation, no GP will say no to a PSA.
Thank you for that. And Tolu, sorry, I think I didn't realize that one was in there. So sorry about that, but thanks that we picked that up. So just on that same thread, so we're talking about asymptomatic. Can you tell us what asymptomatic means? Because we might not know what that is. And also, what is the concern about testing in asymptomatic patients? Why is it a big deal that if I don't have any symptoms, we've got to be careful if I'm having a prostate test? What's the concern, Dr.
Okay. I mean, the first thing, if you remember the slide where I showed the bladder, the urethra, the prostate, when the prostate is normal size, it doesn't have any effect on the urinary passage. And that's where most of the problems come. Prostate cancer, when it starts, doesn't affect the urethra. So there are no symptoms. So to catch it early, if you have symptoms, then it means that it's a bit, I won't say it's late, but ideally, the best time to catch it is when you check it and it's elevated without symptoms. That will be the earliest stage. But then that also has the other side, is that if you are not symptomatic and then the test is positive, there are about 5 to 10 other conditions which can give you a false positive result. So you need to be referred for the urologist to now check you over to do the MRI scan and then decide whether or not this is a false positive. And that is unnecessary worry, which you would not have heard if you did not do the test in the first place. So the main advantage is that if the test is a true positive, the cancer is caught early and your chances of survival are fantastic. That's the main advantage. The disadvantage is that it might be a false positive. And that's where looking at your risk factors before requesting the test becomes useful.
Okay, thank you. Thanks for clarifying that. Thank you. Right. Brother Duncan, can you unmute yourself and very briefly, please, let us know what your question or contribution is. Thank you.
Oh, first of all, I thank Dr. Goma and CAHN for this very insightful session. But I want to get back to something Dr. Goma mentioned about the journey of this. I think there are a lot of Black men like myself that have gone through and positively done the process of baseline PSA, but specifically the process of treatment diagnosis when it comes to myself and a large prostate that's being treated with, which I discussed with a lot of Black men, tamalosin. And what my concern is, even in a benign test like I have with an enlarged prostate, it's about the impact that I realize with the drug that I'm taking. And also, I wanted to get a question about the proper cycle of testing, even in the case of a benign result.
Thank you for that. Okay, thanks. So Dr. Goma would address that for us. You can put your hand down now. Thanks for that useful question. Over to you, Dr. Hector-Goma.
Right. So like we mentioned, one of the causes of elevated PSA is an enlarged prostate, because it means that the prostate gland produces more of the specific antigen. So that's why the MRI scan, which is now the gold standard, is a game changer, because the scan now looks at the prostate gland and checks if there are any areas that look suspicious. And if there are no areas of suspicion, then it means that it's just the benign enlargement of the prostate. So you're now giving medicines to either help shrink the prostate or help it to make it easier for your bladder to hold on to urine. So you now treat the lower urinary tract symptoms. So the point is, the MRI scan helps us to see whether this enlargement, so this elevation, is caused by prostate cancer or by something else like a benign prostatic hypertrophy. So, of course, for some people, when they take the medicines, they have side effects of the medication. I think there are 3 or 4 different medications which are used. So if you're having issues with one, your GP or your urologist can tell you to try a different one or give you a combination of medications. And if all that is not helping and your quality of life is affected, then the options about surgical treatment is offered to try and take away the enlarged prostate.
Thanks for clarifying that. And also just to connect to that, when patients are on medications like tamsulosin or finasteride or similar, can their prostate blood test levels be affected at all, Dr. Goma?
Yes, I mean, that's one of the false negatives. So if somebody, for example, is on treatment for benign enlargement of the prostate with finasteride kind of medicines can give you a falsely reduced PSA level. So let's imagine that the level at which you need to be referred, say, is 3.9 and above for a particular age. And if you're taking finasteride, it can reduce it to 2.9 and you don't get referred. But it's down to 2.9 because you're on that medication. But I would want to believe that, again, it's not every doctor that will be aware of that, but at least for you to know that some medications can reduce your PSA level. So even if it's reduced, either if you know about it, you can mention it to your doctor to say, yes, this looks normal, but I'm on this medicine. And that could now flag up a knowledge to say, yes, let's still refer you, even though your PSA is within normal for your age range, but you're on a medication that can cause a reduction.
Yeah, thank you for that as well. So let's know the medications that we are on. I mean, most GPs are knowledgeable and they would know that if, for instance, you're on finasteride and things like that, it lowers the sort of level at which you need action taken. But if you know what you're on as well, it helps. Now, Sister Catherine, would you like to unmute, please, and briefly ask a question or give your contribution? Thank you. Hopefully you've been given the part. Yes, carry on, please.
Imagine having cancer.
We can hear you. Is that Sister Catherine? Okay, so I'm suspecting that that was probably a legacy hand and maybe not actually Sister Catherine. So Ngozi, can we please unmute that person, please? And then I think there was Sister Gwyneth as well, if you would like to ask your question, please. Gwyneth, would you like to unmute and ask your question, please?
Well, while we're waiting for Gwyneth, there's an interesting chart by Faye, and it's like if your GP refuses a PSA test, ask him or her to document it in your records. And sometimes just saying that alone, people will just back off and then give you the test. So that's an interesting comment.
That's interesting, yes. I mean, to be fair to GPs, I don't think there are that many GPs who would refuse a PSA test for reasonable reasons. I know that there are. I can see Sister Heather giving a look. I think that most people understand the importance of these things, especially when you've got patients who have risk factors. But of course, you always have isolated cases of anything and everything. Okay, Dr. Goma, so some people have had prostate cancer and they're on injections, aren't they? Yes. What are these injections at all? And what are they supposed to be doing? And are they going to be on it for life? Are they going to sort of need it every so often? Are there any tests that their GPs need to be doing while they're on these injections? Are you able to give us a bit of insight into this? Thank you.
Yes, I mean the many times if you remember, one of the slides said in terms of the management, for some patients is surgery, for some patients is radiotherapy, and for some patients is endocrine therapy, which is where you use hormones. The injectables, what they do is to suppress the working of the male hormones, as it were. And these injections, like Prostate, are given every 3 months. And that will be, again, everything is individual, is individualized. So the oncologist or the urologist would now initiate the treatment, and then to say, do this every 3 months, maybe for the next 2 years, and then keep an eye on the PSA level, do PSA levels every 6 months. And the good thing is that we now have a remote monitoring. So they send the patient the forms, or they request the blood test, and then the patient comes to us, we do the test, and then they can see the results and then phone the patient and tell the patient what next to do. And as long as the PSA levels remain where they want it to be, then they can continue with the treatment. And many times, for some people, after 2 years, they have a review. But where, despite the injection, the PSA levels continue to rise, then it means that it's not working. They now bring the patient back in to do something else. So for most patients, it's a 3-monthly injection, which is supposed to suppress activity of the prostate gland. And the PSA level rising is a suggestion that the patient is not responding to treatment. And then they will take the next level, line of action.
Thank you. Thank you. So I've got a question in the chat, and then Dr. Ambrose Nwachuku would like to ask a question as well. So I'll ask him to unmute and ask his question. But the other question from Brother Duncan is, how do we get a GP to approve the MRI test for in-depth investigation? So that's his question. And then Dr. Ambrose, you can unmute and ask. Thank you.
Right. I think that the MRI test is a secondary care initiation. So what you and your GP would need to do is to refer to urology. And then is at a hospital that they will now do the multi-parametric MRI scan. It's not something that we initiate in primary care.
Okay. Thank you. Dr. Ambrose, would you like to?
Hi, Hector, and thank you for such a wonderful presentation. I guess if we look at it from a public health perspective, from primary, secondary, and tertiary prevention, you've talked a lot about the primary prevention, healthy lifestyle, and of diet, exercise, and others. And I guess the secondary one is the testing and monitoring and other stuff. And then tertiary probably treatment and making sure disabilities and others are prevented. I know you've talked about injection, medication management. Are there any other ways to manage them? Doesn't mean if somebody has prostate cancer, is that, shall the person lose hope? Is there a remedy for it? And are there other surgical approaches that may result to people losing their manhood or other things like that? Thank you. I came late. You might have covered it. Sorry.
Yes, I had covered it. I didn't really talk much about what happens in hospital. Being a GP, I didn't want to talk too much about the details, but I was just going to mention here that in this slide, it just shows us the anatomy. So you can see around the prostate, you have nerves and blood vessels and arteries and veins and nerves. And sometimes, however best the surgeons approach in removing the prostate gland, in the process, there may be damage to the nerves that supply erection and the whole process of sexual activity. And most men who have had radical surgery end up losing the erection. And people are different. I remember a very senior professor friend of mine who had, when they told him about the erectile dysfunction, he said, please yank the prostate off. I've used that my manhood for many years. So for some people, they will say, I'd rather die of prostate cancer than lose my manhood. So it all depends. But maybe as, again, science and knowledge improves, you now have robotic surgery, a time would come where you have very fine surgery that spares these vital nerves, that signifies a man.
Thank you. That's very interesting, isn't it?
Yeah.
That's why every care has to be patient-centered. It's not about what you think is best for the patient, but what the patient thinks is best for them in the context of the management options. Thank you for that. Now, Doc, could you briefly address some of the emotional or sort of mental health impacts or relationship impacts? I mean, you've talked about erectile dysfunction, etc., but especially in relation to medication or diagnosis, the impact that could be felt by the patient or even the people around them or their spouses, etc., of the diagnosis, of the treatment, and of the medication that they might be put on. Thank you.
Yeah. Let me start by digressing a little. Sometimes you hear patients would say, I don't go to my doctors. You can never get an appointment every time you call. And if you dive deep down, so when was the last time you tried to reach your GP for an appointment? About 3 years ago. And they have no idea whatever changes are taking place. So likewise, in the management of prostate cancers, like I said earlier on, initially high prostate level, PSA levels, biopsy, which is quite invasive. But now nobody requires a biopsy until you have an MRI scan, if I one. So management has drastically changed. I don't know if there's any part of the UK where an MRI scan is not done before a biopsy. So if you had a PSA level, maybe you're in a hospital where they want to do a biopsy, you could say, no, the standard is MRI scan before biopsy. And if they say we don't do it, I say, well, can I go elsewhere? Because maybe they are not doing that. So the point is that people who have had prostate treatment 10 years ago may have negative experiences, which are quite different from maybe the experience of the last year or two. And I think having opportunities for men who have gone through prostate cancer treatment, maybe in the last few years, to talk to those who are having symptoms may help them to understand better. I haven't had prostate cancer, I'm a doctor, but whatever I say to you can never be compared to a man who's gone through the journey, sharing his experience with other men. So from an emotional point of view, it's good for us. Again, that's where Heather comes in the community, in our churches, our community centers, have opportunities for men to speak to men. Next week is Men's Health Week. I was telling Heather that I want to set up a weekly MOT for Black men for the month of July. because it's something that I've never done in 7 years in my practice, which has a lot of Black community. I've never thought about it. But after preparing for this talk, I said, I owe it to my community to do an MOT for every week in the month of July. So the point is that in the community, we need to have opportunities to have this conversation around what people are experiencing. The other thing is medication. I mean, men in their 50s and 60s are talking about erectile dysfunction. And then if your blood pressure is high, they give you blood pressure tablets. One of the side effects is erectile dysfunction. So people refuse to take their medication. They won't tell you why. Then they have a stroke, unfortunately. So again, some of these medicines may have side effects. You have to weigh the benefits of the medication versus the cost of not taking the medication. You know, at the end of the day, everybody has to make an informed choice. And we, as doctors, we are guests in the lives of our patients. Our role is to tell you the pros and cons, and we leave you and trust you to make the decision which is best for you. It's not for us to pontificate or legislate to you. So I think communication in the community, whether in churches, social groups, men groups, I think that is a fantastic opportunity for us to ventilate and share our thoughts and experiences.
Thank you, and also well done for having that decision, making that decision to offer that MOT service. And Heather, thank you as well for all the good job that you're doing in your community as well. So please let us seek help. Things have evolved. Medicine has evolved a lot. A lot of advances have been made. And so what might have been the case 10, 15 years ago is different from now. So please, let's reach out. Chukwuemeka, you can unmute yourself and ask your question. And then I've got a few more questions in the chat box. If you have questions, please post them. I think we might, after Chukwuemeka, we may not be able to get people to unmute, but I'll try and quickly go through the remaining questions in the chat box. So Chukwuemeka, over to you, please.
Okay, good day. I'm sorry I didn't actually start on time when the presentation started, but I just want to ask this question regarding men being sexually active or sexually inactive. I just want to know the impact of being sexually active or being sexually inactive on the risks of having prostate cancer, because I was in a group of young people, not really young people, people in their mid 40s, right? They were talking about, some people were saying that if you are sexually active, it reduces your risks of being or getting or having prostate cancer. So I just want to know, we're even encouraging in some other people that if you are not that inactive, or if you're not that active, that sometimes they encourage you to even masturbate. So I just want to know, what are the impacts of being active or inactive sexually on one developing prostate cancer?
Thanks, Chukwuemeka, for that question. I remember a few years ago, I read an article where they said regular sexual activity up to 5 or 10 times a week will stop a man from having prostate cancer. So I shared that information with my wife. She just said, that's good for you, have prostate cancer then. So I don't think, like I said, the risk factors I'd shared with you. It might be that at an end, I'm not aware that being celibate increases your risk of prostate cancer. It's not put in the risk factors. But what we know is that if you want to do a PSA, they advise that if you've ejaculated in the last 48 hours, then it shouldn't have a PSA, because that could cause, that stimulation of the prostate can cause you to have an elevated PSA. So Chukwuemeka, the answer for me is that I'm not aware that having sex or not having sex increases your risk of prostate cancer. It may be at an individual level, but at the population level, there is no such evidence.
Thanks for clarifying that. A very interesting submission there, isn't it? Yes. Okay. So Dr. Goma, I might run through these fairly quickly if you don't mind, because of our time. So does subconscious, unconscious or uncontrollable release of urine have anything to do with prostate cancer? So the urine flow is within 1 to 2 seconds of being passed before one goes to toilet. So that's someone's question.
Okay,
Does it have any
that sounds like, is it something like an incontinence of some sort, or an urgent incontinence? I would say any lower urinary tract symptom, particularly for somebody who is 50 and above, have it checked. I know, have a PSA done if you're 45 and above and you're Black. So maybe not, but unless you've had it checked, you don't know. That sounds like passing urine, pre kind of a little incontinent before you actually passing the urine. So maybe not, but just have it checked.
Okay, thank you. Right. So someone is asking, is it okay to have access to the slides, please?
Oh, definitely. I'll send a PDF to you.
Okay, so yes, we can have access to the slides, and if you contact health@CAHN.org.uk, they can send it through to you. So that's goodness, Jeremy, who wanted that, and anyone else. Dr. Goma is happy to share the slides. So Dr. Ambrose says peer support is helpful. Indeed, it is, isn't it? And having these conversations as well, it raises the stigma. It takes the sort of fear factor away from things and makes you realize that actually it's okay to talk about these things. It's okay to reach out for help. So that's absolutely true. Heather says we have cancer champions to peer support and also show, sorry, my chat box has just gone off. Go back to it. Give me 2 seconds, please. Where was I? Scrolling up. Yes, so what's happened to it? Yes, so back to Heather's comment. She's talking about the fact that they have cancer champions to peer support and also show how you can thrive after a cancer diagnosis. So really useful stuff that the BHI is doing in the community. So comment about, what a useful discussion it's been, very helpful discussion. Laura says, this is why early detection is key. If prostate cancer is discovered early and treatment received right away, then life in the bedroom can go on as normal.
True.
Very, very true, Laura. Very true. And certainly complications can be minimized and quality of life improved. Yes. So groups like CAHN are great, is what someone is saying. So thanks for the feedback, and thanks for coming on every Saturday as well to be a part of this program. So lots of thanks and appreciation to you, Dr. Goma, for the session. People giving very useful feedback about how helpful it's been, how educative it's been. Partnership like CAHN helps to disseminate factual information and joined up working to positively impact our communities. Well done. Okay, so well done to everybody. And I'm nearly at the end. Right. I hope I haven't missed out anybody's question. I hope so. I think I've gone through all the questions that we've got. If I've missed anything out, please do forgive me. And you can send your questions to health@CAHN.org.uk. But Dr. Hector-Goma, look, thank you so much for such an insightful session. It's been interactive as well, which has been really good. Heather, thank you so much for coming on the program, for all the great work that you're doing in Leeds, and for all the impact in the community, for all the work that is seen and unseen. Ngozi, did you want to say something?
Yes, please. Thanks, Dr. Diana. We just have Laura on the call to talk for a minute or two on a cancer topic, just something briefly to tell us. I don't know if Laura is on the call to join us before we move on to Heather and Sandy, please. Thank you.
Okay, yes. All right. So should I just finish off with Dr. Goma then? Yes. So Dr. Goma, thank you so much for this. We know that you volunteered your time, you put in a lot of effort into it, and behind the scenes you're doing very great work in the community as well. So thanks to you and to everyone who makes this work week in, week out. We're really grateful. And to all our lovely viewers and audience, if there are any questions that haven't been answered or anything else that you need to ask, please send an email to health@CAHN.org.uk. It's been my pleasure hosting you, and do pardon all the hitches along the way, but hopefully it's all made it fun. Thank you. And over to you, Laura. And after that, it will be to Heather and
Sandy.
Yes, to carry on with the closing remarks. Thank you.
Thank you, Dr. Asante, and thanks to Dr. Goma as well. Very interesting session. What we're doing in the community is cancer awareness, and we work with Black Africans and Caribbeans, some Asians too, so like the BIM community. And I cannot stress it, any further. What I just said, early detection is key. That's what we preach in our sessions every week. Early detection, be it breast cancer, whatever it is, but for prostate cancer, which is our focus today, same thing, early detection, because if it's found early and treatment is given straight away. I know with what I found with our communities is the fact that we never have time. Our men, our women, they're too busy chasing money, doing the extra shifts, and of course I know it's hard for us, upbringing and everything. We have to support the family. You're kind of paying for your immediate family, you're paying for the extended family, you're paying for cousins, you're paying. But I think we should learn to focus on ourselves and look after ourselves very well, so that if you find anything, you go to your doctor straight away, because whatever it is, whatever cancer it is, if it's caught early, trust me, and it's treated early, then you can carry on with life as normal. Unlike when it's late detection, stage 3, stage 4, and it's just really sad that our community, most people die from cancers that can be treated. Women still die from breast cancer in Black community. It's rare to see the Caucasians die from that, but our people, they wait until it's really late. Even with the men, it's late. It's always late stage. But yeah, if we have that that constant reminder of our mind that early detection is key, then yeah, I think life will be better for all of us. Thank you.
Thank you very much. Over to you, Heather, please.
Hi, everybody. Well, my final notes are just to thank everybody and hope that, well, I know that what Dr. Goma presented will be well absorbed and appreciated. I want to thank CATIB, excellent partnership that I'm pleased that BHI are part of. Working together can only make positive changes, which is brilliant. Want to let people know if they've got any questions, want further information about BME Cancer Voice, they can contact BHI, and the information will be given through CAHN. And also to say that together we will be better, and health does actually happen or commences from home. So thank you, everybody. We've got different organisations that are also on here that will provide further information. And then also going on to going on to other things that BHI is doing and how we present more information is Legacy Awards. What we do is we salute excellence, we celebrate it, and it's excellence within all the Black communities. So, showcasing, combating all the issues that we know that are negative stereotypes. But what we do is elevate the successes that we have. The next one is on the 15th of October in Leeds, and tickets are available. Again, just contact us. It would be good to see all of you, if possible, to come and actually celebrate the goodness that we do. And I know CAHN's going to have a table there, which is fantastic. The next thing that we're going to have also is Salute to Reggae. Again, celebrating a genre of music that most people know and appreciate. If you want to attend, please, you can get the tickets from us. Again, it will be based here in Leeds, but you are more than welcome. And those who have been on the health Zooms will get reduced prices. So contact us. Then we have our final big event, which is called Black Music Festival, where ourselves along with CAHN and CATIC will be advertising, promoting the health hours, because they're fantastic. And I think we really need to promote it amongst our own. We are getting invaluable information that otherwise we wouldn't get or wouldn't be shared. So it's an opportunity to find out more. The Black Music Festival celebrates all genres of music, from soca to reggae to R&B to Afro beats, you name it, we have it. 2019, we had over 80,000 people join us. Again, it's free. If you want to come out and just have a good, safe time, it's an alternative to being in Notting Hill, come up to Leeds and say hello to us all. That's just a quick summary of what we'll be doing here in the city region. Thank you.
Perfect. Thank you very much, Heather. So my name is Sandy. I'm the head of community engagement and empowerment at CAHN. So I will be doing the closing remarks. Again, it was a great session today. Thank you very much, Dr. Abiye. Thank you very much, Dr. Diana Asante. Thank you very much to all of you guys who attended the session today. Again, very, very interesting topic. I can't say otherwise, really. So in terms of the updates, we have our next health hour on the 18th of June. It's going to be, well, we'll be looking after your skin, black skin, really. So we have Dr. Kwesi Abiye, who will be hosting the session. Another massive thanks to our attendees online on YouTube and Facebook. Thank you very much for your comments and questions as well. Again, if you would like to suggest any topics for our health hour, feel free to send an email to health@cahn.org.uk. Okay, and in terms of upcoming events, we have our weekly Healthy Heart session. The next session is on Tuesday, this coming Tuesday, the 14th of June. And the topic is herbs and spices. We know we use loads of spices and various herbs in our food, so please do join us. We also have a physical instructor to go with, you know, to host a small exercise for us. We have our Windrush event coming up on the 25th of June. It's a massive event. Please do join us. Please bring friends and family. Register. The email address is on the screen, windrush@cahn.org.uk, or give us a ring if you want to book a stall or if you would like to know anything else. So yeah, I think that's about it. We also have our usual services, the counseling service. Please, if you do know people who are struggling with anything, please do have them to give us a call. We also have our advocacy service. For any issues people are having, please have them to give us a call. A counseling service, you can email help@cahn.org.uk. Domestic advocacy and domestic sexual violence service, you can email, again, help@cahn.org.uk. We're also present on social media. Please feel free to go on our social media every now and then. Most of our activities are posted on there. And yeah, have a lovely week, have a lovely weekend. The weather was really nice today. Enjoy it. And that's it for us at CAHN. Thank you, doctors. Thank you very much. Have a lovely weekend, everyone.
Thank you. Bye.
Welcome to our Caribbean and African Targeted Health Improvement Program, CAHN Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members, and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of in our community. CAHN is funded by the National Lottery Community Fund.